Good morning, everybody. I'm very happy to be here for at least three main reasons. The first is because the Israel Governing Board made decision to organize this meeting here in Sevilla in this convention center, as I think is a very nice place to do that. The second one is because ALPA made decision to organize our press summit meeting. It's very important that we work together. This is a very big problem. It's a burden of disease. Are you listening to me? No? Yes? Okay, sorry. I don't need to touch the microphone. Sorry, no problem. Of course, I think it could be a very fruitful event, and I hope you enjoy both the city, the science, and also the collaboration between all of us. I'm talking. Initially, I was preparing this talk just to analyze how can we improve the management of this disease, taking account the correct diagnosis and management. This is my disclosure that the ISL advised us that we need to show just before every talk. How can we improve the correct management of diagnosis and management of this patient? I think the key point in this disease is a very high burden disease affecting approximately a quarter of the European population. That means we need to work with a very large cohort of patients. Of course, 80–90% of these patients did not develop steatohepatitis and fibrosis. That means they are not at risk of developing major events, major liver-related events. They could develop another ones like cardiovascular, etc. But we are focusing just on the liver disease, trying to avoid any impairment in quality of life. For that, we need to improve our management, and the first step is to segregate patients according to the disease, according to the risk of progression. We need to develop useful tools that could allow us to make decisions correctly. And for that, I think this plethora of non-invasive method with a very nice profile because they are free, they are available in any lab around the world, is easy to do, and of course the interpretation of the results seems to be as much accurate as we can. In the recent years, we developed three main non-invasive methods. The first one was the NAFLD fibrosis score developed by Paul Angulo in USA, and was a quite interesting method to identify patients at risk of advanced fibrosis. FIB4 is a method developed in co-infected patients with hepatitis C and HIV that moved forward to viral hepatitis, and now is playing an interesting role excluding fibrosis in patients with NAFLD. And recently, using the data of the Spanish registry, the EPAMED registry, we developed in Spain the EPAMED fibrosis score. The EPAMED fibrosis score is also a non-invasive method, quite similar to the other, the FIB4 and the NAFLD fibrosis score, but from my point of view, show two major advantages. The first one is EPAMED include HOMA index, that means include the analysis of the metabolic status of the patient, and the second one, EPAMED, but not FIB4 or NAFLD fibrosis score, predict the development of a metabolic alteration in the follow-up of this patient. When we analyze patients with NAFLD demonstrated by liver biopsy, not suffering from diabetes, no arterial hypertension, no metabolic disturbance, and during the follow-up in a couple of years, the risk of developing diabetes, for example, or arterial hypertension was predicted by EPAMED fibrosis score accurately. In this scenario, we can have this method. This method could be available on the outpatient office, in the endocrinologist, in the diabetologist, in the primary care physician. And if you are taking care of a patient with a suspicion of suffering from NAFLD, you can implement this method. It could be highly recommendable that this method will be available directly in the outpatient office, and the physician could request the calculation, the automatic calculation of this method directly in the lab of the hospital, in the central lab, receiving the final score, giving an advice if the patient could suffer or not fibrosis. The key point is to segregate both groups, patient without risk of fibrosis versus patient at risk of fibrosis. That not means that patient at risk of fibrosis 100% should show fibrosis, but they are at risk, and we need to move forward using a more complementary method that could accurately classify this patient. In the last year, or in the last 9 months, we started working with this tool, implementing these 3 methods in primary care. The physician, when attending a patient with obesity, diabetes, arterial hypertension or metabolic syndrome, patient with hyperechogenicity in the ultrasonography, or patient with raised ALT/AST, they request this combined score using a PAMED fibrosis score, FIB-4, and NAFLD fibrosis score. As you can see, a PAMED fibrosis score is the cutoff selecting or defining patient at risk of fibrosis is 0.12. Lower than 0.12 means no fibrosis. FIB-4 is 1.3, and NAFLD fibrosis score is minus 1.455. That means that when we are using this method, we can exclude fibrosis in 86% of the patient when using a PAMED fibrosis score, and 61% in patient with FIB-4, and 63% in patient with NAFLD fibrosis score. That means that a PAMED fibrosis score could better segregate patient at risk of fibrosis, but we are taking care of a lower number of patients. That means we can afford take care of this cohort because we are saving more than a half of the patient. I don't know if you can see the number, but using the PAMED fibrosis score, just 58 patients out of 425 showed risk of fibrosis. And that means it's a little more cheaper and more affordable for our hepatology clinic to take care of these 58 patients in comparison with the 166. The second aspect is, as many times we are comparing non-invasive methods, sometimes the overlap between all of them is very, very high, and we start working with the combined score. That means we are using the data of these 3 methods to classify patients if at risk or not of fibrosis. And as you can see here, when the patient shows 3 or more points, we use 0, 1, and 2 for each method, depending on if the result, the score is in the low, in the medium, or in the high levels. And when the final score could be from 0 to 6. In patient with 0 or with 3 or more points means high risk of fibrosis. And curiously, the combination score gives us the same number of patients that the PAMED fibrosis score, and 58 patients, 14% show risk of fibrosis when using combined score. I think it could be interesting to use all together. They are freely available. The difference is to include or not body mass index in the calculation of these 3 scores, and it could be very, very useful. I think this could relax the people in charge of managing the hospital. It could relax people on the general population, because we have a very strong tool able to segregate patients with and without liver problems. The second step is what can we do with this patient with a liver problem, because if the patient shows a score lower than the lower cutoff, doesn't matter, and the patient should be discharged. We can use FibroScan. New generation FibroScan is not so new. The last generation FibroScan gives us 2 main results. The CAP, the decibelius per meter, is the viscoelasticity of the liver. It's a parameter that could confirm our patient is suffering from NAFLD, from fat infiltration, and the stiffness of the liver, the KPA, That means how the liver is suffering fibrosis. It's true that the range of FibroScan result in NAFLD is wide in comparison with the result in viral hepatitis, in which is more precise result. But I think putting together both FibroScan and the non-invasive method, we can accurately predict fibrosis. CAP is used every day. This is the wide range, and we detect here that the median KPA in the FibroScan in patients at different stage of fibrosis, all these patients underwent a liver biopsy. In the different stage of fibrosis, you can see how the median is much higher in patients with at baseline altered EPAMA fibrosis score versus patients with a normal EPAMA fibrosis score at the baseline. That means we need to put together and to interpret. It's not the same the result of the FibroScan in a patient with a completely normal non-invasive method in comparison with an altered non-invasive method. At the end, we can release this decision tree in which combining EPAMA fibrosis score and transient elastography, we can accurately know if our patient is suffering from advanced fibrosis. Is the opposite of at the beginning. At the beginning, we are excluding patients without fibrosis. Now we are moving to confirm that patients are suffering from advanced fibrosis, and we can do that in 50% of the patient. That means we can, of course, we are generating a gray zone that we need to address with more, perhaps with magnetic resonance analysis, mainly elastography by magnetic resonance to confirm the final allocation of this patient with and without fibrosis. But the use of these different cutoffs allow us to correctly classify this very big part of patient in the second part, in the part of confirming advanced fibrosis. And finally, on the magnetic resonance tunnel, we are developing many imaging biomarkers. Perhaps the king or the queen is magnetic resonance elastography, MRE. MRE shows several advantages. They could demonstrate, they could use all the liver, not just, it's not the mouse there. Okay, I have a pointer now. Okay, you can see here. It's the magnetic resonance, and you can see the different.
You can have here. No parece.
No problem. No problem. And you can see, you can study all the liver, not just the 100, 500 parts that, for example, explore FibroScan, or 150,000 parts that explore liver biopsy, and you can calculate the stiffness, the KPA, the fibrosis all over the liver. You have a map of the distribution of fibrosis. You can calculate the median fibrosis, and you can accurately diagnose the fibrosis stage of this patient. The main problem with MRE is availability. It's a very low number of centers with this technology, but the second one is a very high, is very expensive, and we have many people in the waiting list for magnetic resonance study from different comorbidities. No? And we can use that in patients in which we are completely sure the patient is not, the patient is in the gray zone. We exclude all patients with without fibrosis, all patients with advanced fibrosis, and in the middle we can use this method. Of course, magnetic resonance changed the landscape of the diagnosis of this method. We can, using magnetic resonance, we can calculate fat infiltration. Of course, we have ultrasonography, we have the CAP, and if higher than 248 decibels per meter, we can define patient with fat infiltration, but using PDFF, the proton density fat fraction, we can calculate again the fat infiltration in the whole liver, and we can use several areas of interest, and we can compare the fat infiltration over the liver. At this time, PDFF is the proton density fraction. That is a software included in the magnetic resonance system. Is the gold standard to know if a patient is suffering from NAFLD or not. It's the best manner to detect fat in the liver. And this is the result of the magnetic resonance. And when we compare, or when we use all these methods, we can try to use the study of fibrosis using EPAM fibrosis score plus transient elastography, exclude fibrosis, confirm advanced fibrosis, and in the gray zone, we can use magnetic resonance elastography. If not available, liver biopsy keep on this part to rescue this patient without access to magnetic resonance elastography. It's another very interesting topic is what are we doing with NASH, non-alcoholic steatohepatitis, or mainly steatohepatitis in patients with more than sample steatosis, patient with inflammation, with ballooning, but without fibrosis. Sometimes we are discussing if we have enough evidence in the literature to be concerned about the prognosis of this patient. We have data favoring that NASH means a more advanced stage in comparison with sample steatosis, but in other papers we cannot demonstrate this impact. I don't know, we need in the future to better stratify patients according NASH or not. No non-invasive method is available yet. We are using in clinical practice. The MILI is a software developed here in the University of Sevilla, in the Hospital Virgen de Valme and Virgen del Rocío, and could allow us to know what is happening in the liver according NASH. But the interpretation and the impact on the prognosis of this steatohepatitis diagnosed by the MILI, the NASH MRI, need to be confirmed in the future. Okay, this is just our first experience. We use MRE, and of course, it's a fascinating tool. Radiology, they enjoy a lot doing that. But of course, it's a method that could be influenced by several variables, and we need to keep in mind all the time what is happening in the liver about inflammation, the iron overlap. The iron is a noise in the liver when using magnetic resonance. Of course, the fat infiltration could change the result. Cholestasis, stasis due to cardiac problems, or even the movement during the breath in the release, during the magnetic resonance study. This is the main part of my presentation. I have some. I'm trying to improve the management, but I realize now that Elena is talking about that, and I'm going a little much faster to just to convince you that the first step in this patient in which we demonstrate the patient is suffering from NASH fibrosis is to recommend a Mediterranean diet and physical activity. In this study from Eduardo Vilar Gomez, including 293 patients with NASH, during 1 year they underwent a dietary intervention plus physical activity 3 hours per week, plus groupal meetings just to improve the behavior. How can we improve the adherence? When at the end of the year we did the second liver biopsy, we compare what is happening between the first and the last liver biopsy. You can see here this slide that NASH resolution in patients that lose 10% was achieved in 90% of the patient. Fibrosis regression at least one stage in 80%. Fibrosis improvement in 100%. But the main problem was 10% of the patient achieved 10% loss of body weight. That means 90% of our cohort, highly motivated, followed every 15 days with group meetings, with physical activity, and with diet intervention. 90% of them did not reach 10% of body weight loss, and they cannot benefit from the improvement. Because if you analyze this figure and you put drugs that after 1 year of therapy who reach 90% NAS resolution, 80% fibrosis regression, and 100% steatosis improvement, we put this pill on the market and we cannot work anymore in our life. But of course, we can do that doing physical activity, diet, education, and we need the help of Elena, because we need to work on a public health system. We need a government that fight against this outbreak, and also people working. How can we implement these so healthy activities in our patients? I think this is the main reason. We have data. How can we demonstrate that the liver is improving, is much better, is healthier 6 months, 1 year after the treatment, and even we can demonstrate that using the NAS-RES, that's the NAS resolution calculator, and we can have 95% security, accuracy of NAS resolution in this patient. This is the recommendation that we are doing, and doing that we can address NAS resolution, we can address fibrosis regression, and perhaps the key points is to regress cirrhosis and stop liver-related outcomes. That is a major threat in the follow-up of this patient. If we need to use drugs, we just showing that the obeticholic acid is showing a 25-27% response in patients with NASH F2, F3 with a second liver biopsy. We are now floating with the FC treatment, drug that cure 100% of our patients. The rest is a little disappointing, but I think if we keep in mind that we are using a second liver biopsy with the different bias that we can detect in this method to define the endpoint, plus I think it's a very strong method. We know that the natural history of the fibrosis is not changing so fast that could be demonstrated easily, and I think it's the first step on a new future in which we need to look for the best combination. This is a multi-axis disease. We have many therapeutic targets, from the microbiome to the metabolic derangement, apoptosis, fibrosis, and I'm sure we need to combine, but also we need to use sequentially, because the health problems of these patients are completely different at the different stage. This is the slide that I was looking for. In summary, we can implement, or we must implement, diet, taking account that calories and the micronutrients should be keep in mind according to the geometry of nutrition. The geometry of nutrition means that if you are eating something. If you are eating fat, you are not eating carbohydrate. If you are eating carbohydrates, you are not eating protein. You have protein, fat, and carbohydrates. A proportion should be done every day. And take care when you are removing a nutrient from your diet, because you can impair or you can lose some opportunity. An example is how bad is a gluten-free diet in non-celiac people, because increase cardiovascular risk. If you are changing the carbohydrate by fat, you are improving cardiovascular risk. Is for example. No? The second one is how can we implement physical activity. It's so difficult. We can change many behavior, but physical activity, we need to educate. We need to have our children running every day, and when they are moving forward to the adult life, I hope they can do more physical activity, more exercise than we are doing. We don't need to be runner or marathonians. We need to do just 3 hours walking every week, no more. It's not necessary to do more exercise. Finally, we need to develop this drug to address the different axes, the gut liver axis, the fat liver axis, taking account that if we are using in the best manner the type 2 diabetes drugs and the obesity drugs, we can improve also the disease in this two focus, combinatorial therapy and sequential therapy, to improve quality of life, the prognosis and the survival of patients with NAFLD NASH, that they are truly at risk of developing liver-related and extrahepatic-related outcomes. That is a treatment of daily life. This is a photo of my group in IRIS, here in Sevilla. Thank you very much for your attention.
Thank you, Manuel. We have time for a couple of quick questions. Microphone, please.
We all know that obesity and overweight can be signs or are probable signs of this disease or NAFLD. But it turns out that also some anorectic people have NAFLD. So I would like to hear you talk a little bit about that, because I think it's a very interesting factor, considering that maybe it says something about the metabolic state. I mean, puts it up on the importance of looking at this disease. I find it very interesting that anorectic people can have this, and I would like to just hear you talk about that. Thank you very much.
Thank you for this question. It's a very nice question. Curiously, the U shape is very common in metabolic disorder. You know that the risk of diabetes is the same in anorexia in people lower than 18 kilos per meter square in the body mass index. In very, very lean people, the risk is the same than in very, very obese people. No? It's the U shape. It's so bad to have very low weight, glucose or anything is in the same manner that if you are showing hyperglycemia or obesity. But it's clear that if you are not obese, you could be at risk of NAFLD. The metabolic derangement is very common in malnourished patients, in patients with extremely low body mass index, and it could be a very, very important factor. It's curious, for example, how some amino acid, choline, for example, deficit of choline could be under the development of NAFLD, and a patient with anorexia is at risk of developing hypocholinemia. And therefore developing liver disease. That means that in patients with normal or low body mass index, we need to explore the disease if we have any suspicion. And in this suspicion, we need to include probably genetic background, because it's different, the risk according to PNPLA3. We need to exclude all-time alcohol consumption. That is not very easy in clinical practice. And at the end of the day, we need to keep in mind this is a so heterogeneous disease that this weekend has been released a paper in Cell Metab that will be published next Tuesday, October 1st, and demonstrating how a Klebsiella pneumonia that a patient extracted from the feces of a patient, this strain of Klebsiella showed a very high alcohol production. So high that the patient demonstrated in blood pathological levels of alcohol, promising he is not drinking anything. When the research take the bacteria, the high alk KPN, Klebsiella pneumonia, put on nude mice develop steatohepatitis. That means we are not just the body weight, we are many things. We are our genes, and we are, of course, our microbiome. And all these aspects should be keep in mind when addressing patients with lean NASH, patients with NASH in spite of not being obese.
One more question.
First, thank you for the presentation. Concerning the non-invasive markers, the HibaMet, FIB4, and NAFLD score, what if these are discordant in the results? They are not the same. What to do? And again, what to do if the non-invasive markers are not in line with the results of the FibroScan? And how many of your patients have this discordance.
Okay. Two very nice question. The first is this is the main reason by which we develop the the combined score. Because I say the patient, you are suffering from advanced fibrosis by FIB-4, mild fibrosis by permafibrosis score, a gray zone for the NAFLD score. And what is the measure? What can we do? This is the main reason by which, as we have in our lab the 3 results in each patient, at the end of the day, we made the decision to combine. It's the only manner to deal that if you are 2 points by FIB-4 and 1 point by NAFLD score, you show 3 points, that means you are at risk of fibrosis. No? And I think we need to make a decision, or using combined score or using just one. Because I think if you are not combining, did not add any word to do more than one of these 3 methods, that I think they are a very high diagnosis accuracy to exclude fibrosis. Just to exclude fibrosis, but as doing in 85–86% of the patient is a very powerful tool. And the second one, what are we doing? It's quite interesting in this study that we present, that we are preparing the manuscript, that here, I don't know, but you can see in the fibrotic patient, in cirrhotic patient, in F4, you can see that the medium, this is the patient with normal epimetric score, lower than 0.12, but suffering from a biopsy demonstrating cirrhosis, and epimetric lower than 0.12. And here, epimetric higher than 0.12, and with a fibroscan around 17 kilopascals. Here is around 11 kilopascals. Yes, no, lower than 10, around 7 kilopascals. In this group, it was 15 patients with cirrhosis in the liver biopsy and a low fibroscan, low epimetric score. We have no, we cannot say which is the winner, but in the follow-up, this patient did not develop any complication, did not develop any liver-related outcome. It's a completely different cirrhosis in comparison with patient with more clear cirrhosis demonstrated by non-invasive method and fibroscan. From my point of view, I think we need to analyze, take in account both for a patient with an epimetric score higher than 0.12, but a fibroscan lower than 6.2 means no fibrosis. And I'm absolutely confident with that, no problem. But in patients with a more advanced disease, I think in my decision making in my outpatient office, I'm taking account more the result of the fibroscan and the epimetric score, if repeated over the time and if demonstrating that the patient is not developing any complication in comparison with the liver biopsy, is just one shot, one photo, and I think we know many limitations of the liver biopsy. But sometimes it could be correct, or sometimes no.
Thank you very much, Manolo. So we have to move forward.